So good afternoon, everyone. Delighted to welcome you to the fourth in this series of webinars hosted by the Fatty Liver Foundation. And let me also take this opportunity to wish you all a happy new year. And certainly we hope that 2021 is going to be a much more promising year on many, many fronts. This particular webinar is focused on a quick review of 2020. Regarding NASH, and hopefully we can use the retrospective of 2020 to perhaps project what we hope for 2021 in terms of NASH. So before we go on, I want to also take this opportunity to thank our sponsors. Without them, these webinars would not be possible, and they are Intercept Pharmaceuticals, Madrigal Pharmaceuticals, Netnogan, and Pfizer. And while they offer their generous support, the Fatty Liver Foundation still maintains editorial content and independence over the educational content of this program. Next slide, please. So by way of introduction, I am Neeraj Mistry. I am the Chief Medical Officer of the Fatty Liver Foundation, and I also hold a position as Assistant Professor in the Department of International Health at Georgetown University, and my Twitter handle is @mysterydoc. Next slide, please. So before we start, it's always important to lay out our disclaimers and disclosures. Just to be very cognizant of the fact that this is not medical advice that we are giving out here. Each patient is different, and your primary care provider and your hepatologist is where you get your main clinical management from. The purpose of this webinar and platform is to actually provide education, to broaden your knowledge base about issues related to NASH, and that hopefully helps inform your doctor-patient relationship as well. Next slide. So I'm delighted with today's panel. We have a wonderful group of experts. Many of you know Wayne Eskridge, the founder and CEO of the Fatty Liver Foundation. And Wayne is our patient advocate in chief, in addition to the other roles that he plays. He has been, to a large extent, leading the fight on patient advocacy in the response to NASH. We're also delighted to have Dr. Raymond Chung and Dr. John Vierling, both of whom have been presidents of the American Association of the Study of Liver Disease. Dr. Chung is the incoming president. He's also the director of hepatology and the liver center at Mass General Hospital. And Dr. Vierling is the director at Baylor Liver Health at the Baylor College of Medicine. I should add that while these panelists, particularly Dr. Chung and Dr. Vierling, come from the medical sector, what really warms our heart is that they've been huge patient advocates. As president-elect, Dr. Chung participated in a webinar of the Fatty Liver Foundation, and now, as his incoming role as president, he's also on our panel. And I like to think that this is his first official public appearance wearing this title. So we are certainly taking it as a signal of his commitment to patient advocacy and patient interest. Dr. Vierling as well was part of the SUN study. He was a co-investigator of the SUN study that was conducted by the Fatty Liver Foundation, which was actually quite a challenge when we started, because it was not believed that we could actually do screening at a community level of a general population using a FibroScan machine. And that actually worked quite successfully, where the SUN study screened over 1,000 people in the community and picked up liver disease. The success of that program is now sort of leading to the second program called SUN2, which is attempting to actually screen many more patients than SUN1. The next slide, please. So just another point of housekeeping, all the disclosures of our participants, that's Wayne's. Next slide, Dr. Chung's. And next slide, Dr. Vierling's. Okay. So with that, I think that's the end of our slides. Let me kick off with the first question to our panelists. So the year 2020 will certainly be a very memorable year for good and bad, in the fact that we've had this global pandemic and it's affected society, medicine, and everything as we know it. But it's also been a year in which we had many highlights as well as hiccups in the NASH field. So my first question to the panelists is, what in your view were some of those highlights of 2020 when it comes to the response to NASH? And what were some of the letdowns or hiccups, as I like to call it, as we went through the year? So Wayne, would you like to kick us off?
The highlight, of course, for us was the anticipation. The Intercept drug would get FDA approval this year or last year. And that was a tremendous thing to the community because, there are no treatments for NASH. And we were just really, we understand the challenge of getting a drug to approval, but it's hard not to anticipate that too much. And then when that was not approved by FDA, it created a real downer for us. And then, of course, COVID just rolled over the community because we all know just how fragile we are when it comes to other kinds of diseases. And so COVID, I think, maybe struck chronic disease patients like NASH and like type 2 diabetics and so on very, very deeply. We dealt with tremendous amounts of fear from patients, lots of dialogue of, what do we do? How do we protect ourselves? What do we expect? So, those were the highs and the lows of the past several months, and it was really such a roller coaster for the patient community.
Absolutely. And it's interesting because obstacles and opportunities are two sides of the same coin. And, the Intercept candidate was something that was so exciting and it was the first therapeutic we were anticipating. And yet when it wasn't approved, it was such a letdown. Over to you, Dr. Chung, your view of 2020.
2020 is a year that we best put in our rearview mirror in any way possible, and certainly, COVID is singularly responsible for that bad memory. However, I would say on the fatty liver front, if you will, despite the being dashed by the information in the news from the FDA that Wayne alluded to, for the Intercept compound, there is, I think, a great deal of hope on the horizon regarding, other approaches to dealing with NASH, and we are now talking about a real array of possible mechanisms that can be leveraged to try to bring about improvements in very important endpoints like liver biopsies, improvements in inflammation, improvements in steatosis itself, of course, and even improvements in fibrosis. And we've seen some promising data emerge from earlier phase studies for compounds that again work through a variety of different mechanisms of action. And I think we can be very encouraged that now we have multiple shots on goal, if you will, and that even if a subset end up panning out, we're going to be left with real options for our patient population. And perhaps we can get into those classes of medicines in greater detail later. But I'm awfully encouraged by the promise in the second half of this year, this past year, of the data presented in association with these new classes of drugs. So so there is encouragement, I think, on the horizon with regard to treatment of NASH, and we look forward to even more of it in 2021.
Excellent. Dr. Vierling, your view of 2020?
Well, I agree with what has been said. I think that it's best characterized as a nightmare that we hopefully will be awakening from as we get more penetrance of vaccine. And we continue until that time to do appropriate social distancing and mask and behaviors that can limit the rate of transmission. We find ourselves obviously in a surge here virtually nationwide and worldwide. And so it is a nightmare that's not completely over. But I do think that there is a strong reason to be hopeful. I think we've also weathered in most areas the storm that we all feared that would befall us all, that had occurred initially in New York City, where you'd have the entire healthcare system overwhelmed to the point that it could not provide the care needed for COVID or patients, more importantly, who had non-COVID needs for medical care, including elective and semi-urgent surgeries. So the issue, I think, before us is that we are still in this era, but as we focus our attention for this conversation on the issues of patients with fatty liver disease, namely non-alcoholic fatty liver disease, I share Dr. Chung's optimism that we are still making progress. And that progress, I think, is going to be realized by increased attention to the metabolic advantages that override aspects of weight loss and its impact on the metabolic syndrome, as well as the impact of a whole host of drugs, many of which target mechanisms that are not only specific to the liver, but are specific to the entire metabolic process that from which is derived the liver disease. So we're getting, I think, a closer and better perspective of understanding of not trying to treat the specificity of the liver, but getting at the root causes. And I think we're all optimistic that as we get closer to the root causes, we not only can address non-alcoholic fatty liver disease, but we can address the unmanaged nature of diabetes in many individuals through weight loss and other mechanisms, help control hypertension and not require a panoply of medications to do so, and to really extend life, because we are well aware that liver disease can take its toll and manifest as liver-related mortality. But the overarching risk for all patients who have NAFLD is cardiovascular risk of mortality. And that brings us to the attention to this focal point of where are the root causes. So I'm optimistic, as Dr. Chung is, that we're getting closer to understanding that better and to focusing our efforts there. And we are learning, especially with the failure to approve obeticholic acid in its phase 3 pivotal trial by the FDA, a lot more about what the endpoints need to ultimately be to have approved drugs in our field. We're not there yet. We don't have really good guidance, as you're well aware, even to industry, as to exactly what endpoints are going to be appropriate for approval. But we've made some real strides. So this has not all been negative. I think it has allowed a pathway to present itself where we can anticipate newer medications with metabolic targets, in particular as the linchpin, can ultimately become approved.
That's excellent. And I want to sort of revert now to a framework that we've always used when we talk about fatty liver disease, which is the prevention, testing, and treatment. Those three areas. And you know, based on this initial input that you have given, you know, an ounce of prevention is worth a pound of cure. And from all other disease issues, we know that we have to do prevention and treatment. It's not either or, we have to do both type of thing. So something on the prevention side, and you've alluded to this, and I think COVID actually brought this up to the forefront and highlighted that the baseline level of health makes people susceptible to the onslaught of other infectious diseases, etc. So we did see in 2020 data that was telling us on different types of diets and regimens to actually promote weight loss and live a healthy lifestyle and diet. And yet, you know, at the end of the day, it's the adherence and compliance to that. So while we're getting data that tells us the diets that work, where are we on understanding human nature and the psychosocial elements of behavior change in order to have greater impact with behavior change and lifestyle modifications and diets? Because that's the toughest thing that we have as care providers in getting that with our patients.
That's really one of the toughest things we face as patients, because you know we struggle with it because I hear it over and over. I get thousands of contacts from patients. You know, it's just kind of overwhelming sometimes as to the struggles that we face as a patient community. But one of the common themes is that my doctor says I should lose weight, and I've dieted and I've tried and I fail, and I don't know what to do. So, you know, one of the problems that I think that is just really huge in our society is that we don't do a good job of helping people make that transition. And there's some, you know, good research out there, but I really feel like it's not focused on in a good way to be successful. And actually, I shouldn't address this to the hepatologists because they really do get it. You know, they're at the end of the line. It's really where we intersect with primary care, where this really becomes such a big issue.
Mm-hmm. Dr. Chung or Dr. Vierling?
Yeah, I would agree that you know, we all know that there are great merits to bringing about weight loss through healthy dieting, but that the devil's in the detail of adherence, right? I mean, 90% of patients are really incapable of maintaining adherence to those diets and keeping weight off. And you know, there are few conditions for which there is such a linear relationship between decline in weight and decline in hepatic fat and liver enzymes and ultimately, you know, liver histology. Yet we're still not capable of keeping people, you know, on the right side of the equation. And part of me just wonders if in fact we haven't really fully tapped into the real capabilities of technology in this regard. I do know that you know, where we have the ability to have either wearables or digital communication between sort of our providers and our, you know, our in this case our scales telling us exactly what our weight trends are. If we can just simply get patients onto scales and either reinforce to them you know, the positive trends that they're exhibiting, or for that matter, alert them to reversals or negative trends, and then you know, follow up that reinforcement with, you know, with additional encouragement to get back on the dietary wagon. I think these are all, you know, relatively low tech solutions to getting you know, getting folks to sort of, you know, stay with the program. But you know, I don't think it's going to take anything more complicated than that to try to make that kind of plan work. It really comes down to the initial commitment and perhaps the initial scare of the patient really understanding that you know, that to fall off of that path really has dire consequences. And I think it's that which we must continue to reinforce, even as we develop all these wonderful therapeutics. I think the cardinal nature of all of this still remains absolutely clear.
Well, I agree with what has been said. I think that the issue that pertains to weight loss, particularly in overweight or obese adults, it always comes with a measure of a sense of prior failure to either achieve weight loss or to maintain it or both. And, it sets a sort of a negative loop in people's minds. I think that it's pretty clear, however, that if we look at the bigger picture of what transpires metabolically after bariatric surgery for people that are morbidly obese and have perhaps 100 pounds of extra body weight, that it's enormously clear that it improves everything from the liver to the diabetes. I mean, it can terminate the state of being diabetic, hyperlipidemia, hypertension, etc. So we kind of know that weight loss is integral to controlling this root cause of metabolic dysfunction. And therefore, we want to continue to pay attention to it. I think that the issue of how we do that lacks the concept either of interaction at a physical level with appointments or a digital corresponding level of supervision and guidance. I mean, this is what people, I think, crave. And when you look at some of the emerging successes, there are little hints that you can do better. Those that really get into and maintain this kind of supervisory relationship with Weight Watchers can do well, and they now have a digital platform. The Go Low people, they have a digital kind of reminder platform as to dietary content and portion control. The newer kid on the block is the Noom, which uses cognitive behavioral therapeutic approaches. It's an entirely psychological approach in terms of education against the backdrop of maintaining a strict record of what you actually eat and weighing daily. And it's all electronic, it's in an app. So we've tried to look at these things and see how we might use them. But I think that this theme is emerging that Dr. Chung is touching on, that we can probably do better than having different sort of proprietary resources from which a patient can choose to kind of do the studies necessary and have something that's much more globally available. Now, having said all of that, the sad truth is that you're very easily defeated in a desire for weight loss, given our access to cheap food that will maintain or increase your body weight. I mean, it just is, in essence, we can call it, summarize it just in the terminology of fast food, but it's not good for us. All the diets point that out. And it is something that is heavily advertised to us and marketed and made accessible. And so there's a great pull to not be able to lose weight. And then lastly, we all know that from a medical standpoint, we talk about one of the root physiologic changes for the metabolic dysfunction, including non-alcoholic fatty liver disease, being hyperinsulinemia. The concept that the insulin amount in your circulation is higher than it normally should be for the glucose level simultaneously in your bloodstream. And these are definitely involved in people that say, I diet, I restrict calories, and I can't lose weight, because once they take a diet that increases insulin overexpression, hyperinsulinemia, it will drive those calories to be maintained in fat. They won't lose the fat. And in fact, they'll start to be hungry because their calories have been stored as fat and they haven't been available to their brain and muscle. And it just kind of is a vicious cycle. So that there are physiologic things that we can adapt to, where people start a diet in a certain way and transition to a different type of diet on the longer run. but getting the initiation of weight loss and changing the metabolic nature and the amount of hyperinsulinemia in all the studies that I'm aware of has been a very crucial first step if you're going to start and ultimately maintain weight loss.
So that's great feedback. And this is something at the Fatty Liver Foundation that we've been spending a lot of time thinking about. And I want to draw out that point that you mentioned, this whole notion of supervision. And this is what community-based support is. It's about that coaching. It's about that sort of motivation type of thing. And I think technology is an incredible motivator as well, but it can also only go so far. And it's that human engagement and connection which might foster greater accountability for people to be adherent and compliant. And so as you think about multidisciplinary teams in managing liver health in patients, what are those gaps that we need to fill? I mean, we certainly can't ask hepatologists to be those life coaches for people to maintain a regimen. What are some of those sort of capabilities and capacities that we need in order to get that higher level of adherence to lifestyle changes in the patient community?
Well, I can
Want to go first?
go ahead. That's really a question for one of you guys.
Well, I wish I had a really an answer that we knew was effective. But we do know from the cardiovascular types of studies that Dr. Gatti had performed at the Baylor College of Medicine back with the DeBakey in the era when there was a large number of cardiac bypass surgeries being performed for coronary artery disease, that supervised weight loss and the so-called heart healthy type of diet, was effective, and that required meeting their particular program with a registered nurse who had dietary training and supervised a diet on a weekly weigh-in basis, so it was an appointment. And immediately you start to think in terms of, could you actually then extrapolate this for millions upon millions of Americans? You're talking about a real infrastructural and economic challenge. I'm not sure that that's the answer, but they were successful in a group. And of course, we transcended that with better medications for hypertension, diabetes, and ultimately hyperlipidemia. But at that time, that was the approach they took. If we fast forward, our emerging concept of obesity centers, handling essentially the metabolic syndrome within them, do have bariatric specialists in terms of diet and supervision. They have often psychologists that are trying to work on what I think would be largely a cognitive behavioral therapy alternative as to how to substitute what you are doing with something else in a more mindful way of what you eat and how much and when, and what your triggers are for eating. We have done some work at Baylor College of Medicine with a Menninger clinic, which is the psychiatric component of the Baylor College of Medicine, on extrapolating addiction medicine and psychiatry to the issue of chronic obesity. Emphasizing not so much the addiction as if it's a drug, but the fact that there are pathways being triggered by taste and by smell and by other things that kind of encourage an ongoing intake. And we haven't gotten very far with whether this is or is not the right approach, but I'll just share that we're thinking in those terms. And then there's the issue of exercise. And we have, especially with patients in our liver clinics, often obese, often having joint issues, often osteoarthritis, but sometimes rheumatoid arthritis or other disabilities that kind of limit what the options are for the concept of easily performed exercise. And what we have focused attention on for such patients is exercise in water, where we can use the buoyancy of the human body. And you don't have to be a swimmer. We're not talking about swimming laps. We're talking about literally getting in a pool and walking in water, or moving the extremities in water against that resistance in a programmed way of exercise. Because we know that these people cannot walk long distances, or certainly not often able to ride a stationary or a regular bicycle, et cetera. So we're trying to find a way to get some muscular exercise. And the resistance component of exercise in water, or resistance in just general exercise, is now, I think, well established as a very important aspect for weight loss and maintenance of weight loss, because it's building muscular strength, and it's building muscle uptake of glucose and utilization of energy, independent of aerobic exercise, which we focused on for decades. And it's really not enough. Aerobic plus resistance exercise has, I think, a compelling literature that it's the right mix.
And that's great for our patient community to understand, because it's not just about drugs and diets, but it's about the exercise, it's about the mindset, the motivation, the mental state, etc. Sir George Allain was the head of the Pan American Health Organization, and he speaks very eloquently about the environment that predisposes to non-communicable diseases. And, you know, one of the things that the three things that he talks about is legislation, regulation, and taxation. And he draws on many examples from the world where there's been successes in sort of turning around obesity epidemics. And just in 2020, the State of Obesity report came out in the United States that said there was a 43% prevalence of obesity, not overweight, of obesity. And in childhood and adolescent obesity, it was 19% prevalent. So that is really, really worrying. And it's not static, it is on an upward trajectory. So Dr. Chung, as the head of the leading organization and institution on liver health, how can the patient community and what is the sort of vision on influencing that environment? Sure, we need to do more R&D, but ultimately we have to change that environment that affects patients' lives and their baseline level of health. So what are your thoughts on that?
Thank you for asking, Neeraj. And I want to, again, amplify what Dr. Vierling just spoke to in terms of the fact that you know, this is going to have to be a multi-front assault on all of the factors that promote and predispose to fatty liver disease. And again, as we've been harping on, weight is literally the 200+ pound gorilla in the room. And it's really addressing that. And so I'll get to the ASLD in just a moment, but what I really want to just say here is that maybe what we can do that we haven't really leveraged yet is to use patient support groups, to use patient advocacy groups to provide support for people afflicted with the condition. I mean, much in the same way that we've done with alcohol use disorder and providing a whole variety of means for patients to rally around each other in support groups such as AA and others like it towards abstinence. In a way, the abstinence here is toward reducing food intake, and I do wonder if we can borrow those strategies in terms of just sort of relying on our communities to sort of say, listen, let's all help each other reinforce these behaviors around consumption and quantity of consumption and type of consumption. You know, this can start in the household with family members who, again, you know, much as we declare a household alcohol-free, we would do the same thing here in terms of everybody committing to that new diet in that household, all members of the family. And so I do wonder in that vein whether we enlist our advocacy groups to provide essentially that same kind of supportive network for one another, to sort of say, well, listen, I mean, I'm having a hard time with my management of my fatty liver. What can I lean on? Is there a support group that I can lean on, and perhaps get that, not just encouragement but coaching from peers, as it turns out, peers who've actually suffered through the same condition, and in some ways, are highly relatable in that regard. And so when I think about ASLD and what we can do, of course, in addition to supporting the research that leads to the treatments that we've described earlier, I think that what we have made a big push on in the last year plus has been to get to let patient advocacy groups into the tent, so to speak, and really to allow them to interact with one another, and to develop educational campaigns, information campaigns, patient communications and flyers around disease management, but as well as interpretation of guidelines and guidances for their communities. And I think these are all, really important dimensions of the advocacy mission. But I do think that within that is the opportunity really for groups to develop the support mission for one another, and we are again pleased and happy to help develop and work with patient groups in that regard, because as it's already been said amply, this is perhaps the single biggest aspect to getting our arms around the care of NAFLD.
Absolutely.
Yeah,
Wayne?
let me comment on that, because one of the things that is characteristic of advocacy groups is we really are a peer-to-peer group. We're all people that are fighting the same fight. And I think that the part that is missing for us is that we need professional input with the group, because we can talk to each other endlessly and we understand each other, but we have a hard time knowing what is the right information. We do a lot of research and get a lot of advice, and our foundation tries to provide the best guidance that we can to people. But when we talk about how a peer group functions on a local level, we don't have a neighborhood contact that can help those people on a more specific basis, that can do it, can respond to the short-term needs that people have for, making decisions. And this whole business of weight loss is you make thousands and thousands of decisions in between all the times you see your doctor, and those decisions are what add up to your health. So finding a way to take the peer groups that we have built already, we do have lots of peer groups, but finding a way to bring expertise to them in a way that works well is the problem, because there's a canyon between the specialty, really skilled caregiver group and the patients that actually are living down on the ground.
Absolutely, and to that point of knowing what to do, I mean, in this day and age, patients are inundated with information, and so I want to pivot to testing. And 2020 was an interesting year for testing, because we're entering this realm of non-invasive tests, and there are many tests on the market now, everything from looking at biomarkers to different types of scans. And then there's also, the gold standard, which was the biopsy. And so given that all of this is happening, are there efforts underway to look at consolidating some sort of testing protocol or sequence with the various combinations that we have? And what can we anticipate in terms of screening and diagnosing and monitoring when it comes to these tests? Dr. Vierling, do you want to kick it off?
Well, it's an extremely important question, and I don't think that we have a definitive answer, but we are starting to see more data coming forward and more meta-analyses of comparison of non-invasive techniques to diagnose NASH, distinguishing it from NAFLD, and to, more importantly, diagnose those people with NASH that have progressive evidence of fibrosis, the ones that are at risk of liver-related mortality. And this becomes very important when we just do the math. If we look at estimates, and of course, estimates vary, but if you take a roughly 290 million adult Americans, there's about 90 million to 100 million that have evidence of non-alcoholic fatty liver disease. Now, the evidence varies as to who did what study and how it was extrapolated. But if you then look and you say, well, what is the risk factor? Well, I already mentioned that the risk factor for such a patient through the metabolic pathways is premature cardiovascular mortality, mediated either through coronary artery disease, the potential for a stroke, or cardiorenal disease with diabetic nephropathy being a leading cause now of need for dialysis and kidney transplant. So all of that said is that everybody's at risk with the excessive cardiovascular mortality. We want to be able to meet their needs. That's I think what this discussion is saying. Now, if we switch over and say, okay, what about the people that have more of a specific risk of liver-related mortality in addition to the risk of cardiovascular mortality? I think that we are trying to come up with a way that will identify in an operator-independent manner so that there's accuracy that's going to be independent of anybody specifically doing the test to characterize inflammation of the liver and the presence of fat and the potential degree of fibrosis. Where do we stand now in that? Well, there are some experimental and investigative techniques for inflammation using magnetic resonance spectroscopy as part of an MRI analysis. We already have magnetic resonance elastography, which is a measure of liver stiffness, which of course is a surrogate for fibrosis or scarring, stiffness being contributed to by advanced scarring. And so we have the potential that will work, but we have it being based on MRI. This means that you're talking about hundreds of thousands of dollars, if not $1 million piece of equipment dedicated currently to cross-sectional imaging for modern medicine and not readily available. If we look at the things that do exist and have FDA approval, you could look at the computer, the CAP fiber scan to look at a degree of steatosis, which is very imperfect quantitatively, and the measure of liver stiffness through this transit elastography methodology, and it has much to benefit patients, in my view, because it combines an analysis in one procedure of content of fat and the presence of fibrosis. That alone does not mean that you're dealing by any means with a liver disease that could be characterized as NAFLD or NASH alone, because that's the backdrop of all these millions of Americans. They could have other things, and they need a differential diagnosis. They could have viral hepatitis C, especially genotype 3. They could have hepatitis B. They could have any number of other diseases. So a certain screening needs to be done. It will not be completely accurate, but it will help us, I think, categorize patients who need to be seen and investigated by hepatologists. And although we've talked a little bit about this, I think it's been tangential. So I'd like to be a little bit more precise. We don't have enough hepatologists to handle the aspect of management of the metabolic syndrome and obesity. It just can't happen that way. If we are doing our job, we really need to impact those that have established liver disease that has a progressive nature and to really be incisive to try to change that trajectory. Because we are never going to be able to transplant the number of patients who could end up with decompensated cirrhosis due to NASH. But the millions do not compute to the number of hepatologists. So this needs to be a team sport. And we have to be in a co-managed care relationship with what I defined loosely as an obesity center. Or you could call it an obesity, diabetes, cardiovascular prevention center, this multidisciplinary team, but we've got to be able to co-manage patients. But to do so, we really have to be, our share has got to be focused on those that are going to benefit most from our hepatology knowledge and our ability to change their trajectory of disease. Now, the last part of that is that the vast majority, and thank God this is the case, of patients who have non-alcoholic fatty liver disease are not going to progress in their expected normal life expectancy to advanced liver disease. The rates of progression are being more perfectly known, and they bode well that a lot of people with non-alcoholic fatty liver disease, they have fat in their liver, have all the metabolic consequences, have the increased cardiovascular risk, but they're not really at risk of cirrhosis, decompensation, hepatocellular carcinoma. And we have to kind of triage that in our minds. And I think that this multidisciplinary care model must be established. It must be supported, I think, by science and evidence. It must be supported ultimately by guidance and recommendations, but it's also going to need legislation, in my view, that we have to give this a national priority. And quite frankly, it ought to have a global priority because the United States is not unique in having this incredible burden. We can just itemize countries that have it, and its health impacts are enormous.
And it's very interesting because the test is static. It's at a moment in time, and it doesn't necessarily tell us about a trajectory. And what we're trying to do now is understand what are those social and environmental correlations that might point to a trajectory. Wayne is very eloquent when he talks about in the Sun study, when we showed patients the test, he calls it the teachable moment. And that's been really, really important for us. Wayne, do you want to talk about the teachable moment when it came to screening?
Yes, we use the FibroScan, and as part of our process, we didn't just give people the scan or do the scan. We actually gave them the information, and we talked about what it meant, and we provided them with a lot of information. And there's that point in time when the mind is ready to accept some new information. You know, we get hit with so many messages all the time, and 99+% of them just go by us. But if we can catch people at a moment when they are ready to accept information, the teachable moment, if you will, and we created that using the FibroScan because that's such a dramatic presentation of, you know, something that relates to them physically. And so we found that to be very effective. So we need more tools like that, which give us a window into the person that we can translate then to an educational moment. And then the challenge, of course, is how do you maintain the educational process long enough for them to successfully make some changes in their life as a result of it.
And 2021 is going to be an exciting year where we link those people who go through screening to a peer network. Before we go to our audience for questions, and certainly raise your hands, and Gabriella will put you in a queue to ask your questions. I want to ask Dr. Chung, what advice would you give, medical advice, and certainly each patient needs to consult with their PCP, in terms of getting the COVID vaccine based on different stages of liver disease that a person may have? you know, all the way from NAFLD to cirrhosis?
Excellent question. So I would say this, Neeraj, that that we are awfully encouraged by the data from the 2 FDA-approved vaccine formulations, both the Pfizer vaccine, has proven to be extremely effective across a whole variety of patient groups, as has, of course, the second most recently introduced vaccine. And what I would just say is that while the numbers of patients with chronic liver disease has been relatively limited in those trials. In fact, the Pfizer trial did not really describe a chronic liver disease population per se. The Moderna vaccine trial included a couple of hundred patients with described as having chronic liver disease, and they did very well from the vantage point of tolerating the vaccine. No significant adverse events or disproportionate adverse events in that group of patients, admittedly small. I would say then an extrapolation for current use then is that patients with certainly with non-cirrhotic forms of liver disease should, regardless of etiology, including fatty liver disease, should absolutely undergo a vaccination because it has been proven to be safe in those patients. And even in patients with cirrhosis that is compensated, that is to say, patients who have not experienced full-blown liver failure or portal hypertension like ascites, encephalopathy, variceal bleeding, those are patients who I think, again, we're awaiting further data, but I would say that the collective evidence thus far supports the idea that compensated cirrhotic patients can get vaccinated safely. Of course, the usual caveats about allergic reactions and a history of allergies will apply, and these are, of course, this is CDC and FDA guidance in this regard. But I do think that as a whole, when we think about patients with liver disease, I think that the benefits far outweigh the risk when it comes to moving forward with vaccination.
And given the comorbidities, chances are that patients with liver disease fall into that high-risk population that are prioritized, right?
Right. What's very interesting is if you look at those who do get COVID-19, and there have been clearly a number of studies that have evaluated this, population studies, and what's absolutely clear is that those patients with decompensated cirrhosis are at greater risk for severe outcomes. Now, interestingly enough, those severe outcomes may not be COVID-19 per se, but it may actually be a hastening of their decompensated liver disease. Regardless, they're at risk for an adverse clinical outcome. For those patients with cirrhosis, there are varying studies have made a variety of conclusions, some suggesting that there is an increased risk for those with compensated cirrhosis of adverse outcomes, and others perhaps less so. But I would say that in the main, that we should treat our cirrhotic patient population as if they are at really increased risk should they contract COVID-19. So for that reason, I think the argument falls squarely in favor of vaccination.
Excellent. That's sound counsel. So we have our first hand up. Gabriella, can you unmute so Jules can ask his question?
Jules.
Yeah.
Oh, Jules, can you unmute yourself?
Hi, can you hear me?
Yes, thank you.
Hello, everybody. Thanks for the webinar. Hello, Ray, Dr. Chung, and Dr. Vierling. John, can you hear me? My question is for you. Long time no speak. You've switched diseases from hepatitis to what's getting all the attention now, fatty liver disease. My question for you is this. In the context of HIV and HIV negative people too, you talked about FibroScan. And so how would you do an initial, and I'm sure you're familiar with the study showing or suggesting, preliminary studies, suggesting people with HIV appear to have a higher risk for fatty liver disease than people without HIV due to various things, including the drugs they've taken and HIV itself. But that as an aside in the context, the big question is for them as well as HIV negatives, how do you go about your initial screening? Do you do a fibroscan initially for people who you think might be at risk? How do you decide if they're at risk? And if you do an initial fibroscan, and as you said, you're not sure what it means for sure. So if they come back with, you know, good numbers on liver disease in terms of fibrosis and the CAP score, if they come back with normal numbers, but maybe they have elevated or abnormal lipids and they have HIV, do you then move on to further testing or do you leave it as it is? And what would that further testing be?
Well, thank you for the question, Jules. And it's very complex as you phrase it. And let me see if I can answer specific parts of it. I think first, when we're talking about who should be screened, whether you're HIV positive or not, we want to start with the issue of your risk factor analysis. And do you have metabolic syndrome risk factors? Now, there's going to be patients with HIV and many without HIV who also have the potential for fatty liver disease that we never want to overlook, such as an early Wilson disease patient with a fatty liver, for example. So there's a differential diagnosis, and I already mentioned genotype 3 hepatitis C, which creates quite a fatty liver as an example of where we could become confused. So we could be looking at abnormalities of liver enzymes as a trigger point to say investigate for etiology. And we could look at metabolic syndrome because we know that you do not have to have elevated enzymes to actually have NASH or actually have a risk of progression. We know both of those things are true. So it's threading the needle between the two of those. And from my personal standpoint, having recently addressed for the National Lipid Association in a formal invited lecture, the issue of when to refer to a hepatologist, i.e., who's doing screening in primary and other care entities, and then when you get to the need for a hepatologist, I think that the data currently suggests by availability and by the dual nature of detecting fat plus a fibrosis signal in terms of stiffness, the CAP-equipped FibroScan as a form of transient elastography is superior. Now, superior to what? Well, the other non-invasive things that we have, including panels and using enzymes in equations or platelets in equations or specific levels of circulating compounds in FibroSure and FibroTest. Those things are really only detecting fibrosis. They don't do anything to help us detect fat. So I'm trying to get something that detects both. That's where I come to the recommendation. And this has already been mentioned as being the linchpin for the SUN study that Wayne has conducted and done 1,100 or so examples. So that would be my first recommendation. Now, if I find something there, I still am interested in a differential diagnosis, and I'm still interested in what's going on with the metabolic syndrome. And so this gets me closer to what I was referring to as a multidisciplinary care. In our academic situation, I have people in our division of endocrinology that have done extensive NIH R01 funded grant research in terms of the interface of diabetes and NASH, for example. So I have colleagues that can handle aspects of the diabetes. I have other colleagues that specialize in cardiovascular risk prevention that are quite well known for that. So I have access to have people seen. My advocacy isn't that everybody's going to have access to people like I have access to. We ultimately need a broader multidisciplinary continuum into primary care that can address these things, because you do need to address things that are other than liver related, because it is the metabolic syndrome. It's multiple things, and they need to be addressed. So I do also pay attention if they have high score for fibrosis, because I know that a stage 3 fibrosis has a confidence interval that clearly extends into cirrhosis and vice versa. So I do have currently sometimes a desire on individual basis to go toward a diagnostic liver biopsy to clarify further what we're dealing with and how we might manage it and how urgent the management is. And principally, the issue there of the big picture is, when do you start surveillance imaging with or without serum alpha-fetoprotein every 6 months for hepatocellular carcinoma surveillance? And that's very important. We never want to underappreciate that need, because patients under surveillance is designed that were a tumor to develop a primary liver cancer, we would detect it most likely at an early enough stage to do something about it. And so we definitely want to pay attention to that particular subgroup of patients. Now, you mentioned already that some of the medications may pertain to this, some of the metabolic changes that might be complications of chronic HIV infection, variation in the use of the antiretrovirals, times on, times off. All these things may play a role, and so we need to have the infectious disease experts for this patient population in the mix of the multidisciplinary care team.
So if I could follow up on that, just to ask, if you have a person, HRV or not positive, and they do a CAP and they have some risk factors like abnormal metabolics, a history of ARTs, something like that, and they do a CAP and a FibroScan, and the testing comes out normal, what do you do then?
Well, I would have to say that, in contrast, where I was talking about uncertainty at the high end, it could be an F4 cirrhosis and masquerade by a number that would make you think it's F3 and not yet cirrhosis. When you go to the ends of the spectrum where you have, a consistency of butter, basically, with your FibroScan, with no stiffness at all, and you have no evidence of fat, that it has very good negative predictive value, which is really what you're getting at. How certain are you that they don't have something when they have nothing on the scale? And you're actually fairly certain. Your positive predictive accuracy is where a lot of the variation is, but it has very good negative predictive accuracy in the 98 to 99% probability. So I would be very confident in such a patient. Now, if they have abnormal liver tests, I still want to investigate why they have abnormal liver tests. I just wouldn't be concentrating on the probability that they have a NASH or NAFLD as the explanation.
Thank you very much. That was a great answer.
Thank you, Dr. Vierling. Michael Bradley, Gabriella, can you unmute him, please?
Yes, we actually have Linda Stefano first. Michael Bradley will have a chance to ask his question next. So Linda, I'm going to unmute you now.
Mine is more of a journey of NAFLD with metabolic syndrome. For 2 years, I went through the hamster wheel of doctors not believing me that I was exercising and that I wasn't losing weight. I was on Weight Watchers. I was on the Heart Healthy diet from my PCP, my gastroenterologist, and my endocrinologist. And they all kept telling me that I wasn't working out enough. And I was working out 7 days a week, 30 minutes a day, sometimes an hour. The weight just wasn't coming off. And as doctors, I would hope that you would be mindful and listen to your patients, that when they're telling you that they are working out and they are doing everything that they are doing, that you listen to them and believe them. And I'm not trying to be pointing the finger and being upset or angry at you, because I know that you see a lot of people, but the metabolic syndrome is such a brick wall, so to speak, of different things that are happening in the body, that it wasn't until I met my hepatologist that sent me to a bariatric weight loss center, and they put me on a medication to help suppress my appetite, that the weight started to finally come off along with the exercise. So I just wanted to bring that up, that is an option maybe for some patients that are really struggling. I mean, when you're down to 1,400, 1,300 calories a day, and you are hungry all the time, when you have metabolic syndrome, no matter how much you eat and you're still hungry and you're never satisfied, it's really hard to explain that to somebody when they're telling you you need to eat less and you need to exercise more. And it's like this vicious wheel. And I just wanted to let you know, since the middle of November, I've been on a appetite suppressant medication, and I finally dropped 15 pounds. And I'm finally now able to not look at food as, I'm not thinking about it 24 hours a day, wanting to eat it all the time. And I just wanted to share that with you so that maybe that's something that you could bring to the table with your patients. And I hope that I'm not out of line bringing any of this up. Thank you for letting me speak.
Linda, that was very well said. And what I think we're appreciating more is the doctor-patient relationship is becoming more of a team approach, working together to take this on. But I think that was well said.
Well, I think it was well said also. And, you know, we haven't gotten much into a discussion of what kinds of drugs and drug classes may be ultimately of greatest benefit, keeping in mind the millions upon millions of people that need to derive a benefit. And that you've now addressed, I think, something that is increasingly important, and that is medications to control appetite and to allow weight loss to occur. And it's important to recognize that we do have FDA medications for that. They've not been the best. If we go back historically, phentermine was among the first. It was then added, that was added to fenfluramine for the fen-phen that was so popular at one time, but unfortunately, the fenfluramine caused significant toxicities in terms of the risk of pulmonary hypertension and pulmonary valve abnormalities, and it was banned. You fast forward, and I think that Dr. Chung was alluding in his opening remarks to some of the progress being made and some of the things reported at the most recent AASLD meeting in November to a class of compounds that are these glucagon-like protein receptor agonists. And one of them that's FDA approved for the treatment of diabetes, liraglutide, is also FDA approved solely for the treatment of overweight and obesity, independent of having diabetes. So there are these classes of compounds, and if you're watching television, as many of us do, you're going to see ads right now, nightly, regarding I never know the trade names. I try to stay with the generics, but the semaglutide, that's where people are saying, and I lost 12 pounds in addition to helping my hemoglobin A1C. So we are increasingly able to look at a patient, look at their metabolic syndrome, and to come up with ways that can be pharmacologically helpful in weight loss. And I think that the trend is there. And my hope is that many more drug developers will focus on that, because that one change, as I mentioned, is the linchpin. If you can control that aspect of weight and reduce the weight, you actually impact positively every aspect of the metabolic syndrome, including the liver. And so it makes a lot of sense to target weight loss with pharmacologic help. And there comes a time after pharmacologic help has been successful, you get to a brand new thermostat of your appetite and your weight and your metabolism. And so it may not be that you need pharmacologic support forever. It may be just a into a different thermostatic setting of your own body's metabolism.
Mhm.
It's
So-
just great things.
Yeah, so we had a bit of a delayed start, so I'm gonna run a few minutes over. We'll take Mark's question and then we'll have closing remarks.
Michael Bradley?
Michael, yeah.
Yes.
Hello.
Hello, we can hear you.
Oh, great. Hi, my question regards the FibroScan. In my journey with NASH, it seems to me that FibroScan is very valuable. When I first got a FibroScan test back in July of 20, my scores were 352 comp and 12.3. I had another FibroScan about 2 weeks ago, and the scores are now 206 and 7.6, which to me is a great indication I'm making progress. And I have a new doctor now, much to my chagrin, but he is very discouraging. He's not on my team. He's very discouraging about me getting the FibroScan more than once a year. To me, I need a little more guidance than that. And to me, it seems to me prudent to get a FibroScan every 3 to 6 months. And he says that's overkill. There's not going to be that much difference. Can you tell me if there's any guidance on frequency of FibroScan tests and if they're meaningful in the way that I'm using them?
Dr. Chung?
You know, Michael, thanks for sharing your story. I would say that in general, our tempo for acquiring FibroScans has historically not been much more frequently than annually. While I understand that there could still be dynamic information gleaned from a FibroScan in terms of possible changes in less than a year, our own sense, I think, here is that particularly with regard to fibrosis, maybe a little bit less so with steatosis, that the needle moves a little bit less rapidly in a time span under a year. That said, it is, from the vantage point of assessing fat, which can be more dynamic, and if this acts as some version of a biofeedback, which it really does seem to do for you, Michael, it is a very inexpensive tool, and it's perhaps something you could even request potentially from your provider and say, well, listen, I mean, it's something that maybe you could just get for your own benefit, just to have that quantitative information.
I did that, and he flat out refused.
Perhaps a primary care provider can help you with that.
Right. Well, that was what I was going to say, because I told him if I didn't get it this last time within the 6 months, I would have never known that I'm making such great progress. And his response to that was, well, maybe it's a fluke.
Yeah. Well, it sounds like you've lost some weight or done some substantial things here, right?
Oh, I have. I walk 7.5 miles a day. I've lost 30 pounds. My diet is nowhere near what it was. I'm, taking the extra virgin olive oil every day, a couple of tablespoons. I'm also taking this, a vitamin called choline. And he goes, well, it's not FDA approved. I can't tell you anything about it. So he doesn't sound like he's on my team.
Well, maybe he needs, maybe this is where I think education is so critical, right? And to just amplify remarks made by Dr. Vierling earlier, I do think as we roll out a multidisciplinary model, which is essential, that part of this is going to be educating treaters, because we can't get to everyone as hepatologists, and so this is going to be not only sort of a group effort around our patients using a multidisciplinary clinic type of approach, but also disseminating the word to primary caregivers wherever they are. And then this is certainly something we hope to do through AASLD and our network of experts who can hopefully be the basis for reaching out to those caregivers to meet them where they are. But I do think that this is an education deficiency state as much as anything, and I do think that we want to bridge that gap and fix that deficiency.
I might
Right.
comment just from my experience, because for me, I had the same experience as Michael, and I was fortunate to be able to get more frequent testing without hassle. But I found that the incremental benefit, knowledge of the incremental benefits that I was making was really important to my being able to maintain on the path, because once a year would not have been, would not have had the same motivating effect for me, because I needed to have that proof, I guess, that what I was doing was working for me. And if I could have, I'd have had a fiber scan every 3 months myself, or something. Something wouldn't have to be a fiber scan, but some kind of objective measure as to whether the things I was doing were actually effective.
That's what I'm aiming for. Thank you very much, Wayne, for your input. I appreciate that.
Great question, Michael. And I just want to sort of point out that we have a patient community that has very different levels of knowledge. And certainly the questions show an in-depth and study and engagement on the science and the data. But I think it might be safe to say that with your primary care provider, if a patient has deranged liver enzymes or some sort of liver abnormalities with other risk factors, then maintaining a low threshold for referral to a hepatologist would be important to investigate further if the answer is not obvious. So with that said, I have my last question to our esteemed panelists. If you had one wish for fatty liver disease in 2021, what would that be?
I really come back to what Dr. Vierling was talking about, because infrastructure to support patients that would fit in between the patient community as it exists today and the medical community as it exists. There's this, where the services
Thank you.
aren't really serving us well. And so I would hope to see development of the infrastructure to bind the patient need to the kind of multidisciplinary care that Dr. Vierling spoke so eloquently about.
Excellent. Dr. Vierling?
Well, I've advocated what Wayne has just said. I think that also Dr. Chung is advocating the same thing, a multidisciplinary approach. It's an enormous educational challenge, so I think I would focus on the issues of education so that patients do not feel alone, they feel supported, they have the ability to participate in appropriate groups and to provide advocacy. I think all of those are going to be important. We certainly have to educate the physician community. We're talking about that in many different ways, I think, already. Now, if somebody said, you get one like real wish and you got a magic wand, what I would wish for is that we would come up with a safe and effective drug that would curb the natural components of what generates appetite, ghrelin in the stomach, and the responses that occur physiologically for satiety. That we'd have that drug that could curb those things. Because if we go back to what I was saying about fen-phen, I was amazed at people, medical people, just patients, friends, family, everybody was on this. I mean, people were routinely losing 30, 40, 50, 60 pounds. And, had it not been for its toxicity, we might be having a different conversation here today, because that was back in the 90s when that had occurred. It was quite extraordinary, and something of that magnitude that sufficiently caused purposeful weight loss of that magnitude we already know from bariatric surgery as well as non-bariatric studies is the proportion of weight loss that is required that will completely control the metabolic syndrome and NAFLD and NASH. That'd be my magic wand list.
Excellent. And Dr. Chung?
My wish for 2021 would be if we had a way of basically identifying and stratifying everybody who had fatty liver disease, and I think it's a big ask, but I think one way of getting there, one big step toward getting there is, and it was alluded to earlier, is identifying particular risk groups. So those that come to diabetes clinics, those that are overweight, or particularly those who are obese or morbidly obese. Those are the groups that are likely to have the most severe forms of this disease. And if we could screen every one of them with a FibroScan, and you know, believe me, I think we're now getting more portable FibroScans to get them out to points of care. And I think if we took everybody who attended those clinics, for starters, to get universally screened for the condition, we could then stratify those by at least the severity of disease and those who need attention now, and potentially those first therapies that Dr. Vierling spoke of that will roll out hopefully in the next year or so. And that's what I would wish, that we do a much better job of identifying the epidemic and those who have it.
Well, that was excellent input, and I think those wishes are going to certainly help shape some organizational and institutional strategies, hopefully. So I want to thank you all for participating on this panel, and I want to thank all our participants for tuning in. We will make a recording of this available, and otherwise, everyone be safe, keep your social distance, and take good care.